Science and medicine are evolving in gigantic steps, and today we are part of this magnificent history. So let's take this opportunity to grow up together and to learn together. Thank you very much for the invitation to this prestigious event. My name is Santiago Munoz Palomeque, and today I'm going to talk to you about this new topic that has emerged in the recent years and that has generated a lot of research and questions, which is the robotic surgery and its efficacy against laparoscopic surgery, specifically today in the treatment of liver tumors. So first I have to declare I do not have conflict of interests. And let's begin about talking about the liver tumors. As we all know, liver tumors are divided into benign tumors and to malignant tumors. About the benign tumors, as all know, we have the classification into hemangiomas, focal nodular hyperplasias, and adenomas, among others. These two first kinds of tumors, as we know, do not tend to malignanize usually, but if those grow up and take into a great and large size, this type of tumors can compromise the normal liver function. In those cases, the resection is needed. In the case of adenomas, by the other hand, those kind of tumors, they do tend to malignize, as we have known, and the resection is needed indeed. In relation to the malignant tumors, we have primary tumors and metastatic tumors. About the primary tumors, as we know, we have the classification into hepatocellular carcinomas and cholangiocarcinomas. Hepatocarcinoma, as we all know, those kinds of tumors usually tend to grow into the hepatocyte, which is the liver cell. On the other hand, the cholangiocarcinomas, it can be subdivided into intrahepatic cholangiocarcinoma, perihelial cholangiocarcinoma, and extrahepatic cholangiocarcinoma. In the metastatic tumors, as we all know, these kind of tumors grow up into primary cells distant from the liver. I mean, some location that different from the liver, So the metastatic tumors, usually of the most common, are lung cancer, breast cancer, gastrointestinal cancer, specifically the colonic cancer, and the genitourinary tract cancer, among others. Those are mainly the most common tumors that affect the liver. So what happens in children? As we all know, liver tumors in children are rare and involve at least 1% of all the tumors that affect children. However, we must remember that of that 1%, 2/3 are malignant, which is seriously, and we have to learn about it. So, of the malignant, the most common are hepatoblastoma in 37%. We have also the hepatocellular carcinoma in 21%, and the sarcomas in 8% of presentation. Also, we have other kind of tumors. And talking about the benign tumors, we have the hemangiomas in 15%, we have the mesenchymal hamartomas in 7%, and also the focal nodular hyperplasias in 5%. Even in the actuality, we have a lot of treatment, clinical treatments for the liver tumors. We must remember that liver resection remains as the most effective method of treatment for the liver tumors. So we have to consider that. Specifically, this kind of treatment is recommended for tumors in early stages, also solitary tumors, tumors in cirrhotic patients with Chatbog A or B stages, and also patients with preserved portal venous pressure under the 10 millimeters of mercury. Well, talking about resection, we have to remember there's two mainly types of resection, which are the major resections, which involves 3 or more segments of keynote, as we can see here in those images. And also we have to remember these kind of procedures are recommended mainly in non-cirrhotic patients. By the other hand, we have the small resections that those are subdivided in segmentectomies and inoculations, just depending on the size of the tumor. And also we have to remember these kind of procedures are recommended in cirrhotic patients with a solitary tumor, also patients with preserved liver function, I mean Chatbog stage A or MELD score under 10, and also the absence of portal hypertension. Also, before I proceed, I have to remember that before start with the resection, we must to evaluate our patient, and in this evaluation we have to make the volumetry, the liver volumetry, which is calculate the volume, the total volume of the liver, and the residual volume of the liver after we exclude the tumor in the segment we are planning to resect. This we are going to do through the contrasted tomography computerized, and we have to remember the results. If we have a patient that has a previous liver healthy, the residual volume of the liver must be up to 25%. If we have a volume less than 25%, our patient will develop a liver failure. So the same case in patients that have a previous disease in the liver, such as like cirrhosis. If the residual volume of the liver is less than 40%, our patient will develop liver failure. So we must be secure that our residual volume will be up 25 in healthy patients and will be up 40% in patients with a previous disease in the liver. So continuing with the theme, a number of articles and studies have reported that the application of minimal invasive approaches like laparoscopic or robotic interventions has proved to be safe and effective for the oncological procedures and for procedures in the liver, hepatic surgeries. And those kind of procedures every day are in constant development. So right now those are the best tools we have for these treatments. So continuing into talking specifically about the robotic surgery, we have to remember that since the early 2000s, when the Food and Drug Administration approved the use of robotic surgery in the Da Vinci robot, the studies have been going on, and reports of the advantages of the robotic surgery has every day seen the light. So we can cite advantages like filtration of tremor with minimal invasive fine dissection, also the stability of the instrument for the surgeon, and the 3D view of during the surgery, and also more comfort for the surgeon with decreases rate of conversion to open surgery and rate of complications. All of these are traduced into a a better result into the patient, better control of the pain, and also in case of the recovery. We have to remember the surgical robot has expanded because of these results every day its indications for a wide variety of procedures, including very complex oncological surgeries, those including esophageal gastrectomies, hepatic resections, and pancreatic resections, among others. So the articles in the literature says that endocrine instruments have shown that we can go in, we can do minimal invasive surgery in areas with mainly difficult access. Reported that in laparoscopic procedures are too difficult that are need to convert to open surgery. So the robotic surgery uses images overlay navigation for lesion locations during the liver resections. This technique helps us to improve the orientation of the surgery, and thus this time will increase the precision of resection. Thus, again, repercuting the well improving to the patient, better control of pain, and enhance the recovery. So with all this literature and with all this review of the literature, we have asked and we have proposed and the objective of to assess the benefits and the efficacy of the robotic hepatectomy against laparoscopic hepatectomy in the liver tumors resection. Because of this, we already wrote this review protocol that you can see here in the screen, and we are already been through all the review process. We've been approved, so we started to the review, and we carry on about looking for studies that were comparative, case control, cohort, prospective or retrospective studies that reported at least one of the perioperative outcomes for comparing two interviews. And the patients that must be in these studies were patients with benign or malignant liver tumors, non-cirrhotic or cirrhotic compensated, with these CHALPOG stages A or B. And the types of interventions we compared, as I already mentioned, were robotic versus laparoscopic interventions, specifically hepatectomies. So, as you can see here, we measure a certain kind of outcomes that will help to compare these two types of procedures and to see which one is better, most effective. And these outcomes were the estimated intraoperative blood loss, the operative time, the rate of conversion to open surgery, also the mortality rate, the hospital stay after surgery, and the post-surgical complications. With all of this, we also propose to use the Cochrane study risk of bias assessment to use, and we classified the continuous variables that were put with a weight and mean difference, and while in the other hand the dichotomous variables were pulled using the odds ratio. These were reported with 95% of confidence interval, and also we measured the heterogeneity that was assessing using the I-square value, in which plus or up to 50% mean high heterogeneity and low quality of evidence. So we carry on in the search, and we finally find 38 articles that were selected, in which we applied the exclusion criteria, and remained 11 articles in which we are based our review. Of all these 11 articles, we obtained 1,024 patients of of the study, divided thus into 350 patients for robotic hepatectomy and 674 patients for laparoscopic hepatectomy. Of these 350, 211 were men and 139 were women, and 329 were men into laparoscopic and 345 were women into laparoscopic. About the age, the mean age of every procedure were 61 years into the robotic hepatectomy and 60 years into laparoscopic hepatectomy. I must to recall, we didn't exclude the patients for their ages, so every patient with any age were included into this review. So continuing, here you can see a table with an abstract of the 11 studies that we took for the meta-analysis. So we can see here in the design mainly and the main results. Continuing the main outcomes of the study, we are going to talk first about the estimated blood loss during the surgical act. As you can see here in this table, just 4 studies of the 11 analyzed reported this variable. And here, after the statisticals, we can see that laparoscopic hepatectomy had more blood loss than robotic hepatectomy. This result was statistically significant, but the heterogeneity was too high, 72%, that led us with inconsistent data, and these results must be continuing evaluating in the next studies. So continuing about the operative time, we can see 6 studies reported this variable, and we can see that the laparoscopic hepatectomy acted as a conditioning factor for shorter duration against comparing to the robotic hepatectomy. This result also was statistically significant and also had a high heterogeneity. However, these data, as I will mention later, are too consistent with other reports. Talking about the conversion rate, we can see 9 of the 11 studies reported this, and we up to the conclusion that laparoscopic hepatectomy had more higher rate of conversion than robotics. This wasn't statistically significant, but we can analyze it's also related to the reality. Continuing talking about the mortality rate, we can see of the 6 studies of the 11 that robotic hepatectomy acted as a protective factor, and we can see that laparoscopic hepatectomy had a lot more mortality rate than the robotics. However, these results weren't also statistically significant, but had an heterogeneity low of 0%, which puts in doubt all these results. Continuing, we had the hospital stay after surgery reported by 5 of the 11 studies, and here we can see that there wasn't bigger difference between these 2 studies. However, the robotic hepatectomy acted as a factor for an early discharge in comparing to laparoscopic. So this wasn't statistically significant, but it had also a low heterogeneity of 36%. And finally, talking about the complications, also 6 of the 11 studies reported this variable, and we can see that there wasn't significant differences. And also we can see that there was statistical differences and low heterogeneity of 26%. Well, that's our results. But what do other authors say about this? We, after did those analyses, proceed to look now the meta-analysis about the same thing, and we found the next. Talking about the estimated blood loss during the surgical act, we found that greater blood loss was bigger in laparoscopic against robotics. The same results are seen in the studies of Camaraja et al. And Colera et al., where they also evidenced a significantly less blood loss into the robotic hepatectomies against laparoscopic hepatectomies. As we can see here, both of them statistically significant. However, there are studies that show results of a significant increased blood loss into robotic hepatectomy versus laparoscopic, such is the case of this study of Hu et al. And also Wang et al. However, those studies put in doubt the results of the knowledge and led us to remain the question: is it better? So we have a new question for research. Continuing, we have the operative time. In the operative time, we found that there's a lower average duration in laparoscopic hepatectomy, statistically significant, and the laparoscopic hepatectomy acted as a conditioning factor of a shorter duration in relation with robotic hepatectomy. Such is the cases of those studies that shown a longer duration of robotic hepatectomy, comparing it to laparoscopic hepatectomy in a statistically significant way, such the case as Hu et al. And Camaraja et al., Hu et al., also Wang et al., and Wang et al. In all the studies we can see the significance. However, other studies didn't observe significant differences in the operative time between robotic and laparoscopic, such as the case of Ciogas et al. And also Colera et al. One of the both cases statistically significant, as we can see here. This makes us think, and indeed, robotic hepatectomy takes longer than laparoscopic. However, it may be possible to achieve a duration similar once the necessary expertise has been acquired and the learning curve has been achieved by the surgeon. However, this remains as a research question for the next research that we will do. Continuing, the conversion rate. We found higher conversion rate was reported in cases of laparoscopic versus robotic hepatectomy in a non-statistically significant manner with homogeneous dispersion of the data. Here we can see a similar result where a significantly lower association was found between the conversion rate in robotic versus laparoscopic hepatectomies. For instance, Hu et al. With statistically significance, and also Colera et al. With statistically significance. By the other hand, we have found also that other studies didn't find significant differences in conversion rate between robotic and laparoscopic, such as the case of Ciogas et al., Camaraja et al., and also Hu et al. However, those results weren't statistically significant, as we can see. Also, we have to mention that Hu et al. Describe the main causes of conversion, which are hemorrhage, adhesions, and oncological and technical concerns. Continuing talking about the mortality rate, we can we found that robotic acts as a protective factor to avoid the mortality in a statistically insignificant way. Also, we found an homogeneous dispersion. However, none of the review meta-analyses agreed with our results, and it was reported that they didn't show significant differences related to the mortality between robotic and laparoscopic, such the case of Ziogas, Camaraja, Hu, and Wang et al. This data, as we can see, indicates the current safety of both procedures, showing that both robotic and laparoscopic hepatectomy have low mortality as procedures, so they both are safe, and we have to take this to consideration when we are planning to do the hepatectomy. Also, there's a factor that also takes a big place in the decision that are not studying here, but I should mention that, which is the cost of the intervention. As we all know, the robotic right now has a cost more elevated to the laparoscopic, so we have to consider this, especially in the patients who has not the resources to do to achieve and to be used the robotic hepatectomy. So continuing, we have the hospital stay after surgery. We found there wasn't significant differences between both procedures, and there was an homogeneous data dispersion. Also, we found that robotic procedures could act as a factor for early discharge. So in this, we have to consider that. By the other hand, we found that laparoscopic hepatectomy had significantly shorter hospital stay in robotic patients, and this described in the Coleras study. However, Hu et al. Described that robotic had a longer mean length of postoperative hospital stay than laparoscopic, and in this case wasn't statistically significant. Other studies didn't even show significant difference between both procedures in relation to the hospital stay, such as Hu et al., Scientex et al., Camaraja et al., Wang et al., and also Wang et al. Finally, talking about the complications, we didn't find significant differences between both procedures. However, other meta-analyses didn't show significant difference between those, and they were same result as we found. Such studies as Wang et al., Camaraja et al., Ziogas et al., and Wang et al. This leads us to think that both robotic and laparoscopic hepatectomy are equally safe in terms of complications. Another result to take in another variable to think when we are planning to interview the patient with an hepatectomy. So, looking all of this information, we finally arrived to these conclusions. The robotic hepatectomy is more effective than laparoscopic hepatectomy in avoiding intraoperative blood loss and to avoiding conversion rates. However, robotics duration is longer than the laparoscopic one, but it can be improved with practice, maybe. There's a similarity of both procedures in relation to the days of post-surgical hospital stay, the mortality, and also the rate of post-surgical complications. And finally, robotic intervention could help prevent mortality and act as a factor for early hospital discharge. However, this last one is not statistically significant, so we have to do more studies about it. And that leads us to our recommendations. What do we do now? So, although the robotic hepatectomy provides more benefits than laparoscopic surgery in certain ways, the surgeon who performs the procedure must have the most experience and have completed their learning curve to master the robot, and this way obtain the best results during the procedure. Also, more studies should be carried out to clarify these so far non-significant results. And finally, new comparative studies focused on pediatric population is important to clarify the results, specifically also in children. So with no more to say, I would like to present you the hospital in where I currently doing my postgraduate specialization in general in laparoscopic surgery, which is the Metropolitan Hospital by the International University of the Ecuador. And also you can see here my data if you have some question and if you need something that I could help, I will be very glad to tell you. So with no more to say, I would like finally thank again to you for the attention and to the organizers of this magnificent event, and have a great day. Thank you very much.